Welcome to the deep dive. We're really thrilled to have you with us today. Whether you're a medical student prepping for rounds, a public health practitioner looking to solidify your frameworks, or you're just incredibly curious about how the systems around us actually function, we've got something fundamentally important for you today.
Yeah, we really do.
I want you to think about the physical world around you for just a second. When you're driving your car over a massive suspension bridge, or when you step into an elevator in a 60-story high-rise, you are placing your life in the hands of a vast, completely invisible architecture.
Right, structural engineering.
Exactly. You almost never think about the tensile strength of those steel cables or the safety brakes in the elevator shaft. You don't notice the engineering at all until something critically fails.
That's a perfect way to frame it, because today we are looking at the exact same concept but applied to human survival on a population scale. We're talking about public health as the invisible architecture of society. Just like that bridge, you rarely notice public health law or the massive, complex machinery of population screening until the guardrails give way and a crisis hits.
Yeah, exactly. So our mission today is to explore how the state actually builds these guardrails. We're going to look at how a government uses its legal authority and the medical technology of screening to protect us. And critically, how it balances that immense power with the absolute necessity of restraint.
And we should mention, we aren't just pulling this out of thin air.
Right. We're using the Oxford textbook of global public health as our structural spine for this conversation. We're taking two very dense, incredibly vital chapters, law and the public's health, and population screening and synthesizing them.
Yeah, and if you're actively reading the Oxford text for your studies or your practice, consider this deep dive a structured, conceptual companion. We aren't here to just read the textbook to you.
Nobody wants that.
No, definitely not. We want to build clear conceptual frameworks. We're going to focus heavily on the why. Why are certain laws passed while others fail? Why do we screen for some diseases but explicitly avoid screening for others?
Right.
The goal is to reinforce systems thinking and pattern recognition, specifically regarding that delicate ethical balance between community safety and individual constitutional rights.
So let's unpack this invisible architecture. And I think we have to start with the legal framework. Because when most people think of public health, they picture, doctors, lab coats, epidemiologists looking through microscopes.
Contact tracers making phone calls.
Yeah, exactly. But the textbook makes a really compelling case that the most consequential public health debates don't happen in a clinic. They happen in legal forums,
Right.
in legislatures, in Supreme Courts, and within administrative agencies.
They absolutely do. Law is arguably the most powerful instrument in the entire public health toolkit. But to understand why, we first have to define what public health law actually is.
Okay, let's define it.
It's defined as the legal powers and duties of the government to assure the conditions for people to be healthy and safe. But it's more than just a set of rules. It's deeply rooted in the philosophy of the social contract.
The social contract, meaning the implicit agreement between the citizens and the state.
Precisely. When citizens agree to be governed, when they give up certain absolute freedoms, the state in return assumes the highest obligation to defend their social and economic well-being. And fundamentally, that includes their health and security.
So the state has to protect us from things we can't fight individually.
Right, like a contaminated water supply, a sudden infectious disease outbreak, or hazardous commercial products.
But that immediately brings us to the core conflict, doesn't it? Because if the state has the power to protect everyone, it inherently means the state has the power to tell me what to do. As a citizen, I might say, I appreciate you wanting to keep me safe, but I value my autonomy. I want to make my own choices.
And that right there is the fundamental friction point that drives almost every major public health debate in history. The tension between the common good and individual civil liberties.
It's a tough balance.
It is. The government needs adequate, robust power to protect the population. But it cannot, and ethically should not, interfere with individual autonomy, privacy, bodily integrity, or private property without a very strong evidence-based justification. Coercive measures require proportionality.
I want to push back on something the text brings up here, because it identifies a specific true north for public health law to help navigate that tension. And that true north is social justice. Now, I know for a lot of clinicians or junior doctors listening, social justice can sometimes sound like a political buzzword. It sounds like something debated on cable news, not something you use to design a clinical pathway or a legal framework.
It's a very fair point, and the textbook is careful to clarify this. In the context of public health law, social justice is not a political slogan. It is a measurable operational mandate. It serves as a guiding value in legal design.
How does that actually work in practice?
Well, the textbook frames social justice as a dual mission. On one hand, the goal is to improve the overall aggregate health of the population. But on the other hand, and this is equally important, the mission is to actively identify and redress systemic, persistent disadvantage.
Meaning you can't just look at the overall average and pat yourself on the back if the numbers go down.
Exactly. Social justice in public health law is the explicit recognition that people whose prospects for good health are severely limited by systemic issues, whether that's poverty, discrimination, or lack of infrastructure, they do not have the same life choices or health trajectories as everyone else. Law can reduce inequity, but if it's poorly designed, it can actually entrench it.
The textbook provides a really brilliant thought experiment to test this concept, and I'd love to walk through it.
Let's do it.
Imagine a government wants to tackle smoking, which we know is a massive driver of mortality. So they enact a huge sweeping policy, maybe a major public awareness campaign combined with some new regulations. And it works. The overall smoking rate in the population drops from 30% down to 15%. On a macro epidemiological level, cutting the smoking rate in half sounds like an absolute triumph, right?
On paper, yes. Most health ministries would celebrate that as a massive victory.
But the thought experiment asks us to look closer at the data. What if that 15% drop was entirely driven by wealthy, highly educated demographics quitting smoking? What if the smoking rate among marginalized groups or institutionalized populations like people in psychiatric care or the prison system remained sky high?
Right.
Or what if the government's public health messaging was explicitly designed to only reach affluent neighborhoods because they had better access to healthcare clinics where the messaging was delivered? Is that still a victory?
Through the lens of social justice, the answer is a definitive no. It is not a complete victory, and it might even be considered a policy failure.
Because it widened the gap.
Exactly. That scenario beautifully illustrates why equality in outcomes matters just as much as overall statistical drops. If a public health law improves the aggregate numbers but leaves the most vulnerable populations behind, or worse, if it inadvertently widens the health gap between the rich and the poor, it fails the test of social justice. The invisible architecture of the law has to be designed to lift the bottom, not just raise the average.
That makes a lot of sense. So if social justice is the true north, and the state has this social contract to protect us, how does it actually steer the ship? The textbook outlines several different models of intervention, essentially the state's legal toolkit. I'd love to walk through these mechanics.
It's a fascinating toolkit.
And for anyone listening, as we explore these examples, we're looking at them purely as factual case studies of how the law functions. Many of these touch on highly sensitive, politically charged topics. But our focus is strictly on the legal and public health mechanisms at play. Let's start with the power of the purse.
The power of the purse, or the tax and spend power, is the quintessential governmental function. It's often the first lever a government pulls. On the spending side, the state uses public funds to build the essential public health infrastructure. This is the invisible architecture in its most literal sense, funding the epidemiological surveillance systems, the state laboratories, the emergency response stockpiles.
The foundation.
Right. But the government can also attach strings to that money, which is where it becomes a powerful regulatory tool.
Attaching strings, you mean saying, we'll give you this funding, but only if you adopt this specific health policy.
Exactly. A classic example occurred in the United States regarding the legal drinking age. The federal government wanted to reduce road traffic fatalities associated with drunk driving among young people, so they wanted the drinking age raised to 21 across the board. But under the U.S. legal system, setting the drinking age is generally a state power, not a federal one. So the federal government used its spending power. They passed a law stating that if an individual state refused to raise its drinking age to 21, the federal government would withhold a significant percentage of their federal highway funding.
Which is money those states desperately needed to maintain their roads.
Precisely. It's an incredibly powerful inducement. The states technically had a choice, but the financial pressure was so immense that all states eventually complied. That's the spend side. The tax side is equally potent for shaping behavior. Taxation can be used to incentivize positive behavior, like offering tax relief or credits for purchasing health insurance or childcare. But more commonly in public health, heavy taxation is used to disincentivize the consumption of hazardous products.
Like cigarettes and alcohol.
Yes, so-called sin taxes. By artificially raising the price of a pack of cigarettes through taxation, you price certain consumers, particularly young people and lower-income individuals, out of the market, thereby reducing consumption and improving health outcomes. Another classic economic vehicle is a carbon tax, which is designed to improve environmental and public health by making industrial pollution financially painful for corporations.
Okay, so if taxation is manipulating the financial environment, another major tool the state uses is manipulating the informational environment. This is all about regulating what consumers are allowed to see, read, and hear.
It is, and this is where the legal battles become incredibly fierce. The state, of course, acts as an educator. It spends money to run public health campaigns, telling people to wear seatbelts or explaining the dangers of binge drinking. That's relatively uncontroversial. But the friction reaches a boiling point when the state mandates what private businesses must tell consumers, or conversely, restricts what businesses are allowed to say.
The clash between public health initiatives and corporate free speech?
Exactly. It's a fascinating legal battlefield, and tobacco control provides the best case study. The World Health Organization's Framework Convention on Tobacco Control explicitly requires participating states to adopt strategies that reduce demand for tobacco. A massive part of reducing demand is restricting advertising and marketing.
And Australia really led the charge there, right?
Australia was a global pioneer here. They implemented strict plain packaging laws. They legally mandated that tobacco companies remove all their corporate branding, logos, and attractive colors from cigarette packs, replacing them with drab, uniform colors and extremely graphic images of tobacco-related diseases.
I can imagine the tobacco industry did not take that lying down. That's their entire brand identity being erased by the government.
They fought back relentlessly. The tobacco companies took the dispute all the way to the World Trade Organization. They utilized international investment treaties, arguing that the Australian government was essentially expropriating or taking their valuable intellectual property, their trademarks and brand designs, without compensation. They argued it was a violation of international trade laws.
Did it work?
Ultimately, no. Australia won those international legal battles, and the plain packaging law stood, paving the way for other countries to follow suit. But it highlights the complexity. In the United States, the Food and Drug Administration tried a similar, though less extreme, route by mandating graphic warning labels on cigarette packs.
And they got sued too.
Of course. The tobacco companies sued, and the case went through the federal courts, eventually reaching the Supreme Court level in various iterations. The industry's argument there was rooted in the First Amendment. They argued that forcing them to put graphic anti-smoking imagery on their own products violated their constitutional right to free expression, effectively forcing them to broadcast the government's ideological message.
It's incredible how a public health policy, designed simply to warn people about lung cancer, instantly transforms into a profound constitutional battle over commercial speech and intellectual property.
That's the reality of public health law. You are always navigating constitutional constraints.
Let's move to the physical world. Another major tool is altering the built environment. We often call this upstream engineering. When we think about health, we usually think about our own bodies, but this is about how the actual concrete and zoning of our cities dictate our health outcomes.
The history of public health is deeply intertwined with the built environment. If you go back to the Industrial Revolution, the earliest public health laws were sanitary laws, building sewers, mandating minimum window sizes in tenements for ventilation to fight tuberculosis, ensuring clean water supplies. Today, we've modernized that concept into urban planning and zoning laws. The physical environment you live in dictates a massive portion of your health behavior.
Give me a practical example of how a zoning law impacts health today.
Think about the concept of a food desert. In many lower-income urban areas, zoning laws and commercial development patterns have inadvertently created neighborhoods where fast food chains and convenience stores selling highly processed, high-sugar foods are everywhere. But finding a grocery store that sells fresh, affordable produce is nearly impossible.
So you're surrounded by calories but starved of nutrition.
Exactly. If a resident has to take 3 buses just to buy fresh vegetables, their physical environment is actively driving them toward poorer nutritional choices and, consequently, higher rates of obesity and diabetes.
So the law created the environment, and the environment created the health outcome.
Precisely. But the law can also be used proactively as a health intervention. Through urban planning codes, a city can legally mandate the inclusion of safe bike paths, separated pedestrian walkways, abundant green spaces, and efficient mass transit in all new developments. When you build a city that way, you naturally incentivize physical activity. People walk or bike to work because it's safe and pleasant, which combats cardiovascular disease, and you simultaneously reduce motor vehicle injuries and air pollution. It's literally engineering health into the concrete.
And that built environment is so deeply tied to another tool, which is addressing the socioeconomic environment. The textbook brings up the SES gradient socioeconomic status. It makes a very strong claim that inequality itself is pathogenic. It causes disease.
This isn't just a philosophical claim. It is a robust, extensively documented epidemiological finding. There is continuous graded association between a person's socioeconomic status, which is usually a composite of their income, their level of education, and their occupation, and their rates of morbidity and mortality. And it's a gradient, meaning it's not just a binary of rich versus poor. At every single step down the socioeconomic ladder, health outcomes get worse.
Why is that? Is it just that people with less money can't afford good healthcare or gym memberships?
That's part of it. Of course, access to resources matters, but researchers argue it goes much deeper. The chronic stress of poverty, the lack of control over one's work environment, the anxiety of housing insecurity, these factors induce a chronic physiological stress response. Your cortisol levels stay elevated, which over time degrades your cardiovascular system and suppresses your immune response.
It physically wears the body down.
It does. Furthermore, wide disparities between the extremely rich and the extremely poor within a single society tend to break down social cohesion and trust, making the entire community more stressful and physically pathogenic.
So how does public health law address that? You can't just pass a law that says, stop being stressed.
Exactly. And you can't just ask the Ministry of Health to fix systemic inequality. It requires a whole-of-government legal approach. Public health law in this context means passing labor laws that guarantee a living wage and safe working conditions. It means housing policies that prevent eviction and ensure habitable living spaces. It means educational funding that is equitable. All of these are public health interventions because they directly impact the SES gradient.
That makes sense, but those are very broad systemic interventions. What about when the government just wants to tell you what to do right now? That brings us to direct regulation. This is the coercive power of the state to mandate behavior, and it's the one people are usually the most familiar with and often the most resistant to.
Direct regulation is where the state sets clear, enforceable rules with penalties for noncompliance. It's the law mandating that you must wear a seatbelt when driving or a helmet when riding a motorcycle. It's the regulation that bans artificial trans fats from being used in restaurant food.
Or professional licensing.
Right, the licensing requirements that ensure a doctor or a pharmacist has the necessary education and competency before they are legally allowed to treat you. And most significantly, it includes the extraordinary powers used in infectious disease control, such as mandatory vaccination for school entry, mandatory reporting of certain diseases, or even the power to quarantine individuals who are highly contagious.
But this is where the friction we talked about earlier really explodes. This is where you hear the term nanny state. If I'm an adult and I know riding a motorcycle without a helmet is dangerous, but I choose to take that risk because I like the wind in my hair, why is it the government's job to stop me? If I only end up hurting myself, isn't that my right?
It's a classic libertarian argument against public health regulation. The counter-argument from a public health law perspective is twofold. First, your individual choices rarely only affect you. If you get into a motorcycle accident without a helmet, you might suffer a severe traumatic brain injury. The emergency responders who have to treat you, the taxpayer-funded public hospital that has to care for you in an ICU for months, the loss of your economic productivity to society, and the emotional devastation to your family, those are all societal costs. The state regulates the behavior to protect the common good from those externalized costs.
But even with that justification, there is a limit to what the public will accept, right?
Absolutely. And we saw a vivid example of that when New York City attempted to implement a direct regulation capping the portion sizes of sugary drinks sold in restaurants and theaters.
Oh, the soda ban. I remember that.
Yes. The public and political backlash was massive and immediate. People were outraged, arguing it was a gross infringement on their personal freedom to choose what they consume. The initiative ultimately failed in the courts. It perfectly highlights that enduring tension. Even if a regulation is supported by solid epidemiological evidence showing that massive sugar consumption drives the diabetes epidemic, if the public perceives the law as state overreach into their private lives, it will fail.
So if direct regulation is politically toxic, the state sometimes tries an alternative route, indirect regulation, specifically through the tort system. For those who might not be familiar with legal terminology, we're talking about civil litigation lawsuits used to force an industry to change its behavior.
This is a fascinating use of the legal system. Instead of passing a new law in the legislature, public health advocates and government entities use existing laws regarding negligence, product liability, or fraud to sue corporations whose products are causing public harm. The prime historical example of this is the Master Settlement Agreement with Big Tobacco in the United States in the late 1990s.
Walk us through how that actually worked. Why did the states sue the tobacco companies?
Individual smokers had been trying to sue tobacco companies for decades and largely failing because the industry would argue that the smoker knew the risks and chose to smoke anyway. But in the 90s, the state attorneys general tried a novel approach. They sued the major tobacco companies not on behalf of individuals, but on behalf of the states themselves.
Okay, what was their argument?
Their legal argument was, your deceptive marketing and dangerous products have caused millions of our citizens to get sick, and the state Medicaid systems have had to spend billions of taxpayer dollars treating them. You need to reimburse the state for those healthcare costs.
That is a brilliant pivot.
It was incredibly effective. The threat of massive liability forced the tobacco companies to the negotiating table. The resulting master settlement agreement was unprecedented. It required the tobacco companies to pay billions of dollars to the states over time. But perhaps even more importantly for public health, the litigation process, specifically the legal phase called discovery, forced the industry to release millions of pages of internal corporate documents.
And what was in those documents?
They unequivocally proved that the industry had known for decades about the addictive nature of nicotine and the cancer risks of their products, and that they had intentionally engineered their marketing to target minors to create replacement smokers.
Wow. So the tort system didn't just extract money, it extracted the truth, which fundamentally changed the public perception and allowed for much stricter direct regulations later on.
Exactly. It was a watershed moment. Naturally, public health advocates have tried to replicate this exact same tort strategy against other industries that produce harmful products, most notably the highly processed food industry and the firearm industry. They've launched lawsuits arguing that fast food companies deceptively market unhealthy products to children, or that gun manufacturers intentionally traffic dangerous weapons in ways that circumvent local laws, creating a public nuisance.
Have those lawsuits been as successful as the tobacco ones?
Largely no. They have faced significant legal hurdles. The fundamental difference is that a product like a firearm or a hamburger, when used as intended or consumed in moderation, is not inherently toxic or defective in the exact same way a cigarette is. A cigarette is the only legal consumer product that, when used exactly as the manufacturer intends, will kill half of its long-term users. Furthermore, these industries have lobbied heavily for legislative immunity to protect themselves from these specific types of public health lawsuits. So the tort system is a tool, but a highly complex and inconsistent one.
Let's look at the final tool in the textbook's framework, which is perhaps the most counterintuitive of all: deregulation. Usually when we think about public health law, we think about adding more law to protect people. But the textbook points out that sometimes the existing laws themselves are the primary barrier to public health.
This forces us to ask a very uncomfortable question. What happens when criminalizing a behavior actually makes an epidemic significantly worse?
Right.
The text uses the example of needle exchange programs to illustrate this. In many jurisdictions, laws exist that criminalize the possession of drug paraphernalia, which includes sterile syringes. The intent of the law is to discourage illegal drug use. But the epidemiological reality is that these laws do not stop addiction. Instead, they force intravenous drug users to share dirty needles, which directly fuels the explosive spread of blood-borne pathogens like HIV and hepatitis C.
So the law designed to protect society is actually accelerating an infectious disease crisis.
Precisely. In that scenario, deregulating specifically, decriminalizing the possession of sterile syringes, or officially sanctioning needle exchange programs is a highly effective public health intervention. It's a harm reduction strategy. We see the exact same dynamic when examining laws that criminalize sex workers or individuals who use illicit drugs. The public health evidence consistently shows that criminalization drives these marginalized populations underground. It forces them into shadows where they face higher risks of violence, and crucially, it pushes them far away from health services, infectious disease screening, education, and social protection.
But I can imagine deregulation in these areas is incredibly difficult politically.
It is extremely politically unpopular. Politicians often want to use the criminal law to signal moral disapproval of certain behaviors. Telling a constituency that you are going to decriminalize drug paraphernalia or sex work is a very tough sell. But the textbook is clear. If social justice and evidence-based harm reduction are our guiding principles, the epidemiological data strongly points to targeted deregulation as a critical tool to save lives.
Okay, we've spent a lot of time mapping out the invisible structural architecture of the law, how it taxes, regulates, and shapes our environment. Let's transition to the operational side of the state's power. If public health law is the structure, the textbook frames population screening as the early warning radar. It's the vast machinery the state uses to actively sweep through healthy populations, looking for hidden threats.
That's a great transition.
But before we get into the complex mechanics of this radar, we have to make a vital clinical distinction that the textbook insists upon. We need to differentiate between testing and screening. What is the difference, and why does it matter so much?
It matters immensely because clinicians and the general public often use the word screening incorrectly, blurring the lines. Let's define them clearly. Testing or diagnostic testing occurs when a patient comes into a clinic because they are experiencing a symptom. They have a lump or a cough or sudden weight loss, and the doctor orders a blood test or a scan to find out why. The patient has initiated the interaction because they feel sick.
Makes sense.
Even if a patient is in the clinic for something minor, like a sprained ankle, and the doctor decides to check their blood pressure or run a cholesterol panel while they are there, that is considered opportunistic testing or case finding.
So the patient is already in the healthcare system seeking care. How is screening different?
Screening, as strictly defined in public health, is the systematic application of a test to a defined population of people who presume themselves to be completely healthy. These are individuals who have no symptoms, who have not asked for medical help, and who are going about their daily lives. The state or the health system is actively reaching out to them, sending them a letter in the mail, inviting them to come to a clinic, to offer them a test, to detect a disease they don't even know they might have.
That seems like a massive ethical shift.
It is a profound ethical shift. When a sick patient comes to you for help, they accept a certain amount of risk from diagnostic tests because they want a cure. But when you, the state, intervene in the life of a healthy person who hasn't asked for your help, the ethical bar for ensuring that your intervention does more good than harm is exponentially higher. You are disrupting their life, potentially causing them anxiety and subjecting them to medical procedures. You better be absolutely sure the radar is accurate.
Which brings us perfectly to the machinery of this radar. We need to talk about the properties of a test. If I'm a clinician in an emergency room, I am likely obsessed with a test's sensitivity. I want a test that never, ever misses a true positive. If someone comes in and I think they might have a heart attack, I want a test that will definitively catch it. But the textbook flips this clinical intuition on its head when we move to population screening.
That's right. Sensitivity is the proportion of people who truly have the disease who correctly test positive. It is a measure of how well the test detects the illness. And of course, it's important. You don't want a screening program that misses a lot of cancers. But in the context of population screening, where you are testing hundreds of thousands or millions of healthy people, specificity is arguably the much more critical metric.
Break down specificity for us.
Specificity is the proportion of disease-free people who correctly test negative. It measures how good the test is at identifying who is truly healthy. Here is why it is the king of screening metrics. Imagine you are screening 1 million healthy people for a relatively rare condition. If your test has a 99% specificity, that sounds amazing, right? It's 99% accurate at identifying healthy people.
That was great to me.
But do the math on that 1% error rate. 1% of 1 million people is 10,000 people. That means 10,000 completely healthy people will receive a false positive result. They will get a phone call telling them they might have a devastating disease.
Oh, wow.
Right. If your specificity isn't nearly perfect, you will instantly flood your healthcare system with an avalanche of false positives. You will cause massive psychological terror, subject thousands of people to unnecessary and potentially dangerous invasive follow-up procedures like biopsies, and completely bankrupt the public health budget, wasting resources on healthy people.
That is terrifying. And this mathematical reality brings us to perhaps the most important concept in the chapter regarding screening: positive predictive value, or PPV. The PPV asks the only question the patient actually cares about. Doc, my screening test came back positive. What are the actual odds that I really have the disease? And the textbook makes it very clear that a test's PPV is not a fixed number. It is intrinsically, inescapably linked to the prevalence of the disease in the population you are testing.
This is a concept that routinely trips up practitioners, policymakers, and especially the media. So let's walk through the exact data anchor the textbook provides to illustrate this. They use a screening test for beta thalassemia, a blood disorder. The test looks at mean cell hemoglobin, or MCH, and they set a strict cutoff at 27 picograms. Now, let's look at this test in two different environments.
Okay, lay it out.
First, imagine we use this test in a high-prevalence setting, say, an antenatal clinic in a specific London hospital that serves a demographic with a known high genetic risk for the trait. In that specific setting, the test has 100% sensitivity. It misses absolutely nobody who has the trait. And because the disease prevalence is high in that waiting room, the positive predictive value is calculated to be about 77.4%.
Meaning, if a patient in that specific clinic gets a positive result, there is a roughly 77% chance they actually have the trait and a 23% chance it's a false alarm. That seems like a very useful clinical tool.
It is highly useful in that setting. But watch what happens to the math when a politician or a well-meaning health advocate says, this test is 100% sensitive, it's fantastic, we should roll it out as a universal screening program for every single person in the entire country.
I'm guessing the math turns against you.
It turns violently against you. When you take that exact same test, the same biochemical assay, the same 100% sensitivity, and apply it to a low-prevalence general population, the overwhelming majority of the people you are testing do not have the disease. Because the disease is so rare in the general pool, the rare times the test makes an error and throws a false positive mathematically drown out the tiny handful of true positives you find. The textbook notes that in a low prevalence area, the PPV of that exact same test plummets to somewhere between 1.3% and 30%.
Wait, so if the PPV drops to, say, 10%, that means if a patient gets a positive result, there's a 90% chance they are perfectly healthy and the test is wrong.
Exactly. For every one true case you find, you are terrifying 9 healthy people. This perfectly demonstrates a foundational rule of public health law and policy. You cannot simply take a diagnostic test that works beautifully in a high-prevalence hospital setting and unleash it as a universal population screen. The math of false positives will destroy the program.
Which perfectly sets up our next major theme and honestly the most counterintuitive part of this entire deep dive. First, do no harm. The paradox of prevention. It sounds completely backwards. We've been taught our whole lives that catching disease early is always better. Early detection saves lives. How could looking for a disease early possibly be a bad thing?
It is a deeply ingrained cultural belief, but the textbook meticulously unpacks the hidden harms of the screening radar system. We are intervening on healthy people, and those interventions carry real risks. The harms fall into a few distinct categories.
Walk us through them.
First, there are the direct physical hazards of the screening tests themselves. Think about cumulative radiation exposure. If you screen millions of women with mammograms or millions of smokers with CT scans over decades, the radiation itself will induce a certain number of fatal cancers that never would have existed otherwise. Then you have the severe psychological harms. The profound, life-altering anxiety of a false positive can scar a patient for years. Conversely, you have the danger of false reassurance from a false negative, where a patient ignores a growing lump 6 months later because the screening test cleared them.
But those are the side effects of the test being imperfect. What if the test works exactly as intended? What if it finds exactly what it's looking for?
That leads us to the most insidious and complex harms in all of public health: overdiagnosis and overtreatment. This occurs when a screening program operates flawlessly. It detects an abnormality, let's say a tiny cluster of cells in the prostate or the breast, that meets the strict microscopic pathological definition of a cancer. However, the specific biological cluster is so indolent, so incredibly slow-growing, that it never would have caused the person any symptoms, and it never would have killed them in their natural lifetime. They would have died of old age or heart attack decades later, completely unaware it was even there.
But because we set up a radar system and actively went looking for it, we found it.
Exactly. And once we find it, and we label it cancer, the clinical and legal machine takes over. We treat it, We subject a completely healthy person to radical surgery, to toxic chemotherapy, to burning radiation for a disease that was never going to hurt them. We cause impotence, incontinence, cardiac damage, and severe psychological trauma, all to cure a harmless biological anomaly that is overdiagnosis.
To really grasp how this happens and why it's so hard to measure, the text requires us to understand two specific statistical biases that distort our view of cancer screening. Let's break these down very carefully because they are crucial for systems thinking. Let's start with length time bias.
Length time bias is essentially a sampling phenomenon, and it distorts which types of disease a screening program actually catches. Imagine you are standing in a river, sweeping a net through the water every few minutes to catch fish. You are disproportionately going to catch the slow, lazy fish that are just drifting along. The fast, aggressive fish dart past your net before you even see them. Cancers behave the exact same way.
How so?
Cancers have vastly different biological growth rates. Some tumors are incredibly aggressive. They grow so fast that they emerge, cause symptoms, and potentially become fatal in the 2 or 3 years between a patient's scheduled screening appointments. These are called interval cancers, and screening programs routinely miss them because they move too fast.
And the slow ones.
On the other hand, some tumors are indolent. They grow at a glacial pace, sitting silently in the tissue for a decade or more. A population screening program that checks people every few years will naturally scoop up a massive disproportionate number of these slow-growing, relatively benign tumors simply because they sit there for years waiting to be found.
And how does that bias the statistics?
It creates a dangerous statistical illusion of success. When researchers look at the data, they see that the patients whose cancers were detected by the screening program are living for a very long time, much longer than the patients whose cancers were detected by symptoms. The researchers declare, look, screening works. It drastically improves survival. But the reality is those patients are surviving a long time because their specific tumors were biologically lazy and non-aggressive to begin with, not because the screening program saved them.
That is wild. It's an illusion created by the speed of the tumor. And that leads right into the second bias, which is lead time bias, which is equally deceptive, but operates on the timeline rather than the biology.
Right. Lead time bias alters our mathematical perception of survival time without actually extending a patient's life by a single minute. Let's walk through a timeline to see how this works. Imagine a woman develops an aggressive, ultimately fatal tumor at age 50. Let's say she doesn't participate in any screening. At age 55, she finally feels a lump, goes to the doctor, is diagnosed, and tragically she passes away at age 57. Her recorded survival time from the date of diagnosis is exactly 2 years.
Okay, 2-year survival. Now let's run the exact same scenario, but we put her in a screening program.
Same woman, same aggressive tumor starts at age 50, but this time she goes in for a routine screening scan at age 52, and the radar catches it early. The doctors begin treatment. However, because this specific tumor is biologically aggressive and unresponsive to the therapies available, she still passes away at the exact same age, 57. The treatment wasn't going to save her regardless of when it started. But look at what happens to the statistics. Her survival time from the date of her new early diagnosis is now 5 years instead of 2.
The clinic statistics look fantastic. We achieved a 5-year survival rate.
Exactly. The program looks like a massive triumph of modern medicine, but the patient didn't live a single day longer than she would have without the screening. The only thing the early detection achieved was forcing her to live for 3 extra years with the agonizing knowledge that she had a terminal disease undergoing toxic treatments earlier than necessary. Lead time bias simply moves the starting line of the diagnosis backward, inflating the survival time without delaying the finish line.
When you combine the physical harms, the massive overdiagnosis of length time bias, and the illusions of lead time bias, it brings us to a concept from researchers Raffel and Gray that absolutely blew my mind when I read it. They call it the popularity paradox.
It is perhaps the darkest irony in all of public health policy. The popularity paradox states that the greater the harm a screening program causes through overdiagnosis, the more incredibly popular the program becomes with the public and politicians.
How does it even make sense? If it's harming people, shouldn't they hate it?
Think about the psychology of the patient. If a screening program is deeply flawed and overdiagnoses 1,000 perfectly healthy people with a cancer that never would have harmed them, those 1,000 people are immediately rushed into surgery and radiation. They endure the brutal treatments, and because their cancer was harmless to begin with, all 1,000 of them survive. Naturally, what do they believe?
They believe the screening program just saved their lives.
Completely. They become fiercely loyal, passionate advocates for the program. They tell their friends and family, this test saved my life, you must go get it. They form powerful patient advocacy charities. They lobby politicians to expand funding for the program. The paradox is that the harm of overdiagnosis actively creates an army of false positive survivors who mistakenly believe the program is a miracle. It creates a self-sustaining cycle of popularity that makes stopping a bad screening program politically radioactive. No politician wants to stand up and tell an army of cancer survivors that their life-saving test is actually harmful state overreach.
The textbook gives two incredible historical anchors to show just how hard it is to stop this momentum once a program starts. I want to look at the stories from Denmark and Japan. Let's start with Denmark.
In Denmark, starting around the mid-20th century, the famous Carlsberg breweries implemented a mandatory occupational screening program. They required routine chest x-rays for all their employees to screen for tuberculosis. Now, at the time they started it, TB was a major threat, and it arguably made public health sense. The problem is what happened later. By the latter half of the century, public health advancements, antibiotics, and better living conditions had virtually eradicated TB in that region. The prevalence was near zero.
So they stopped the X-ray program, right?
No. They continued the mandatory X-ray screening for 20 more years after the disease was effectively gone. For 2 decades, they were exposing their entire workforce to routine radiation. The screening activities were mathematically causing more harm, specifically a small but very real risk of inducing radiation-linked cancers in healthy workers, than any possible benefit they provided against a TB threat that no longer existed. The momentum of the system just kept rolling.
Contrast that with Japan, which the text highlights as a very rare success story of actually stopping a popular program. What happened there?
In 1985, Japan initiated a massive national screening program looking for neuroblastoma, a type of cancer, in infants. They were testing the urine of 6-month-old babies. It was incredibly popular with parents who wanted to protect their children. However, by 1990, an international panel of experts began raising alarms. They looked at the data and realized the screening program wasn't actually reducing the mortality rate from neuroblastoma at all. What it was doing was detecting an enormous number of indolent, harmless tumors that would have naturally regressed on their own. It was classic overdiagnosis.
So they were subjecting infants to unnecessary cancer surgeries.
Yes. They were actively harming babies. But unlike the Carlsberg example, Japan managed to act. Over the next decade, they conducted rigorous, independent reviews of the evidence. They engaged in a massive, transparent public education campaign with the media to explain the complex concepts of overdiagnosis and lead time bias to the parents. Finally, in 2004, the Japanese government officially halted the infant screening program. And because they had laid the educational groundwork, they managed to stop it without causing a massive public outrage. But I must emphasize, that kind of policy reversal is the exception, not the rule.
Okay, we are moving into section 4, where the textbook brings all these concepts together, the economics, ethics, and governance of looking for trouble. Let's talk about the money first, because public health resources are finite. Every government has a budget. The textbook discusses opportunity costs and health economics. Simply put, a dollar spent on a screening program is a dollar that cannot be spent somewhere else.
Precisely. And in public health, we have to measure the value of that spending rigorously. We use metrics like QALY's quality-adjusted life years or DELA's disability-adjusted life years.
Let's break that down, because I hear QALY thrown around a lot.
Yeah.
What does it actually mean in practice?
A QALY is a way to measure both the quantity and the quality of life generated by a healthcare intervention. 1 QALY is equal to 1 year of life in perfect health. 0 represents death. So if a new screening program catches a cancer, but the grueling treatment only extends the patient's life by 2 years, and those 2 years are spent in severe pain or disability, let's say they value that quality of life at 0.5, then that intervention has only gained the patient 1 QALY. That's 2 years multiplied by 0.5.
Okay, the math makes sense. How does the government use that?
They look at the cost per QALY. If rolling out a massive national screening program costs $50 million and it only generates a few hundred QALYs across the population because of the high costs of false positives and overdiagnosis, health autonomists will flag it. They will say, look, if we take that exact same $50 million and invest it in primary care clinics in underserved neighborhoods or in clean water infrastructure or in maternal health programs, we could generate thousands and thousands of QALYs. That is the opportunity cost.
And the textbook notes that the initial proposals for these screening programs routinely underestimate the hidden costs. It's not just the cost of buying the lab equipment.
The initial pre-assessments are almost always overly optimistic. Politicians look at the cost of the test strip or the ultrasound machine and think it's cheap. But a population screening program requires a vast, invisible infrastructure. You have to build massive, secure IT systems to track millions of citizens, send invitations, and manage recall appointments. You have to fund quality assurance boards to monitor the labs. And most critically, the budget almost never adequately accounts for the immense downstream costs of investigating and treating the avalanche of false positives we discussed earlier.
The textbook uses the example of abdominal aortic aneurysm, or AAA, screening in the UK, to show exactly how these economic models can completely fall apart.
It's a perfect case study in systems thinking. The UK decided to evaluate whether to screen elderly men for AAAs, which can be fatal if they rupture. They relied on large randomized clinical trials that proved the screening was highly cost-effective and saved lives. However, those foundational trials were conducted many years earlier, during an era when smoking rates in the population were much higher. And smoking is one of the primary risk factors for developing an aortic aneurysm.
So what happened between the trial and the actual rollout?
Public health law happened. Over the intervening years, the government aggressively utilized the legal tools we discussed earlier: massive tobacco taxation, stringent informational campaigns, and strict indoor smoking bans. These laws were wildly successful at driving down the overall smoking rate. Consequently, by the time the UK actually rolled out the national AAA screening program years later, the actual prevalence of the disease in the population was significantly lower than the historical models predicted.
And as we established earlier, if prevalence drops, the positive predictive value drops.
Exactly. Because the disease was much rarer, the screening program was finding fewer true aneurysms while still incurring all the massive fixed infrastructure costs and generating false alarms. The cost per life saved suddenly skyrocketed compared to the original, highly optimistic estimates. It shows how interventions in one area of public health smoking laws can completely alter the economic viability of a totally different intervention aneurysm screening.
That economic reality forces us onto a very precarious ethical tightrope. We have to balance utilitarianism versus equity. When a government designs a screening program, do they follow a strict utilitarian model, meaning they design it to maximize the total number of lives saved across the entire population, achieving the greatest good for the greatest number? Or do they design it with equity in mind, specifically targeting and uplifting the disadvantaged communities who suffer the highest burden of disease?
It's a profound ethical dilemma. Utilitarian approaches often inadvertently widen health inequalities because the affluent, highly educated segments of the population are usually the most likely to participate in voluntary screening programs, understand the results, and access the follow-up care. If you just open the doors and say, "Everyone come get screened," the rich get healthier and the poor are left behind.
And then there is the incredibly dark history of genetics and stigma. We absolutely cannot talk about population screening without confronting the shadow of eugenics and state-sponsored discrimination.
It is a vital, sobering part of the text. When a government decides to screen a population for genetic traits, rather than infectious diseases or cancers, the risk of profound systemic stigmatization is enormous. The textbook outlines a devastating failure of governance, the United States Sickle Cell Anemia Control Act of 1970.
Let's dive deep into that. Why did it happen, and why was it such a disaster?
In the early 1970s, against the backdrop of the civil rights movement, there was political pressure to address sickle cell disease, which disproportionately affects the African American population. A new, relatively cheap screening test called SickleDex became available. The federal government, wanting to show swift action, passed legislation to roll out massive, often mandatory screening programs across the country. But they did this with staggering incompetence. They rolled it out rapidly without providing adequate public education, without training sufficient genetic counselors, and without protecting the privacy of the data.
What was the result?
Absolute chaos and profound discrimination. The tests identified individuals who had sickle cell disease, but it also identified millions of people who are merely healthy carriers of the sickle cell trait. Being a carrier means you have one copy of the gene, you do not have the disease, you will never get the disease, and you are perfectly healthy. But because the government failed to educate the public or protect the data, employers, schools, and insurance companies got hold of the screening results.
And they assumed trait meant disease.
Exactly. They fundamentally misunderstood the biology. Perfectly healthy African Americans who were merely carriers of the trait were suddenly denied health insurance, charged exorbitant premiums, and systematically fired from their jobs due to fears they would incur high medical costs. The military even grounded pilots who were carriers based on unfounded fears. The government's poorly designed public health intervention actively weaponized genetic information against a marginalized community. It was a catastrophic failure that resulted in profound trauma and led to a deep, enduring public distrust of government medical screening that still echoes today.
Which brings us to a concept that is supposed to protect us from that kind of state overreach. Informed choice. But the textbook questions whether choice is actually real in these systems. If a screening program is technically voluntary, but the state is heavily pressuring people to take it, is it truly an informed choice? For instance, the text mentions that in the UK, general practitioners are strictly performance managed against national targets for cervical screening uptake. Their clinics are literally graded and funded based on how many women they manage to screen.
That creates a massive structural conflict of interest. If a doctor knows that their clinic's funding or their professional standing will be penalized for low screening rates, how aggressively are they going to push a hesitant patient to consent? The pressure can easily cross the line from education into coercion. The text cites a researcher named Marteau, who provides a very rigorous definition of informed choice. Marteau argues that for a choice to be truly informed, it must meet three criteria. It must be based on relevant knowledge of the risks and benefits. It must be consistent with the decision-maker's own personal values. And it must be behaviorally implemented, meaning they actually do what they intended to do.
So if a patient just rolls up their sleeve and does what the doctor tells them because they trust the white coat, without actually understanding the risk of false positives or the dangers of overdiagnosis, that is not an informed choice. It is just compliance.
Precisely. True informed consent in population screening is incredibly rare because the mathematical concepts are so difficult to convey.
And to really drive home how complex that relevant knowledge is, let's look at the number needed to screen statistics the textbook provides. These are the actual numbers you would theoretically have to explain to a patient sitting in your clinic to get true Marteau-level informed consent.
These numbers are staggering when you hear them laid out plainly. According to the data in the text, to prevent one single death from colon cancer over a 5-year period, you must screen 1,374 people. For breast cancer, to prevent one single death, you must screen 2,451 women.
And what about cervical screening?
The statistics from a major Bristol study on cervical screening are even more complex to explain. To save one life from cervical cancer, you must screen 1,000 women continuously for 35 years. And in that 35-year process, you will generate 150 abnormal results causing immense anxiety. You will refer 80 of those women for highly invasive investigations like colposcopies, and you will subject 50 women to actual surgical treatments. All of that collateral damage is required to prevent one single death. That is the true mathematical reality of population screening. How do you communicate that nuance on a glossy trifold pamphlet in a waiting room? It is incredibly difficult to achieve genuine informed consent under those conditions.
Okay, we've laid down the deep foundations of the legal architecture and the screening radar. In Section 5, we are going to apply these frameworks to real-world case studies and systems thinking. We are going to mirror the textbook's comprehensive scope here, moving chronologically through the lifespan and thematically through the major categories of disease. Let's start on the law side, looking at the big three health hazards. First up, infectious disease.
Infectious diseases have historically dominated the entire field of public health law. The oldest international health regulations on the books relate directly to quarantines, maritime border controls, and sanitation to combat things like cholera, yellow fever, and the plague. And even today, infectious diseases receive wildly disproportionate global funding and intense political attention compared to their actual modern disease burden.
Give us an example of that disproportionate funding.
We see it with massive multi-billion-dollar global initiatives like PEPFAR, which targets HIV/AIDS, or the Global Fund, which targets tuberculosis and malaria. Make no mistake, these are devastating diseases that require funding. But the reason they command such massive legal and financial responses is because pandemics terrify politicians and the public. An outbreak moves fast, it crosses borders, and it feels like an immediate existential threat.
But the textbook notes that the real killer today, the thing actually driving global mortality, isn't infectious disease at all. It's NCDs, non-communicable diseases like heart disease, cancer, chronic respiratory diseases, and diabetes.
Exactly. NCDs now account for roughly 63% of all global deaths. And there is a lingering myth that NCDs are just rich country diseases of affluence. The text shatters that. Lower income and middle income countries are currently facing a devastating double burden. They are still fighting the traditional infectious diseases with limited resources while simultaneously being absolutely crushed by rising tides of obesity, diabetes, and smoking-related illnesses as their economies transition.
And how does public health law tackle NCDs? You can't quarantine someone for having diabetes.
That's the challenge. Tackling NCDs legally requires moving far, far beyond the health ministry. You cannot solve the obesity epidemic with a scalpel or a pill. It requires a whole-of-society legal approach. To reduce NCDs globally, public health advocates have to engage in complex global trade law, intellectual property disputes, and agricultural subsidy reform. They have to fight to reform the global food system, heavily restrict the marketing of ultra-processed foods, and implement the severe tobacco and alcohol regulations we discussed earlier. It's a much slower, much more grinding legal battle than fighting a virus.
The third big hazard is injuries, which make up about 17% of the global disease burden. The text paints a really stark, tragic contrast between high-income and low-income countries here, specifically regarding the built environment.
In high-income countries, public health law has been incredibly effective over the last century at reducing traumatic injuries. We implemented strict vehicle safety standards, mandatory seatbelt laws, strict drunk driving enforcement, and we designed traffic-calming road infrastructure. But in rapidly urbanizing low- and middle-income countries, the legal frameworks and the physical infrastructure simply haven't caught up with the population growth.
The textbook uses a very specific example here, the Kibera slum in Nairobi, Kenya. Let's expand on what's happening there.
Yeah. Kibera is one of the largest informal settlements in Africa, housing hundreds of thousands of people in a very dense, unregulated area. The built environment is deeply hazardous. Residents there suffer inordinate rates of severe road traffic injuries. Why? Because the public health law, the zoning, the infrastructure funding has failed them. They are forced to navigate chaotic, high-speed arterial roads that completely lack safe pedestrian walkways, separated bike lanes, or pedestrian bridges. Thousands of people have to walk to work or school across active, dangerous traffic flows daily. The laws and the physical environment are actively causing traumatic injury on a massive scale.
Now let's switch back to the screening radar and apply it across the human lifespan, exactly as the chapter does, starting at the very beginning. Antenatal and newborn screening. What are the major ethical and legal controversies here?
The major debates in newborn screening center heavily around the unintended consequences of advanced genetic testing. When we take a newborn's blood spot, the heel prick test, to screen for serious treatable conditions like phenylketonuria or cystic fibrosis, the biochemical tests often inadvertently reveal the infant's carrier status for other genetic conditions like sickle cell or cystic fibrosis.
And as we discussed earlier, being a carrier just means you have the gene. It doesn't mean you are sick.
Right. And that creates a profound ethical dilemma for the clinician. Do you reveal this incidental carrier status to the parents? The infant obviously cannot consent to knowing or sharing their own genetic information. Furthermore, being a carrier won't affect the child's health at all during childhood. It only becomes relevant decades later when they reach reproductive age themselves. Many ethicists argue that dumping this complex genetic data on anxious new parents causes unnecessary stress and violates the child's future right to privacy.
And there's another hidden landmine in genetic screening, isn't there? The issue of paternity.
Yes, the uncomfortable reality of non-paternity. Routine genetic screening for inherited diseases occasionally and unavoidably uncovers the fact that the biological father of the child is not the man the family thought it was. It vividly demonstrates how a seemingly simple, routine biochemical test designed to protect a baby's health can inadvertently detonate a family's entire social structure. The radar sees things you weren't looking for.
Moving into adulthood, the controversies around cancer screening are arguably the loudest and most heavily debated in all of public health. Let's touch on the big three the text covers: breast, cervical, and prostate cancer.
With breast cancer screening, primarily mammography, the clinical and epidemiological debate is fiercely polarized. On one side, massive clinical trials do show a mortality benefit. Mammograms absolutely save lives by catching aggressive tumors early enough to treat, but critics point to the staggering collateral damage. They argue that the widespread overdiagnosis of harmless lesions like DCIS, the immense psychological anxiety of the inevitable false positives, and the cumulative radiation risk from decades of annual mammography severely offset much of that mortality benefit. It is a constant balancing act of harms.
Cervical cancer, conversely, is generally viewed as a massive public health triumph, isn't it?
It is, but it's a triumph of organization as much as technology. The UK's cervical screening program is a prime example. They built a highly effective, legally mandated call-recall IT system, which systematically tracks every eligible woman, invites them for screening at specific intervals, and rigorously follows up on abnormal results. That organized system drastically reduced cervical cancer mortality. And now, the field is undergoing a massive technological transition. We are moving away from simple visual cytology, the traditional pap smear, and transitioning toward advanced DNA testing for the HPV virus itself, coupled with the rollout of the preventative HPV vaccine. The hope is that the vaccine might eventually render widespread, invasive cervical screening obsolete altogether.
And then there's prostate cancer, specifically the PSA blood test. The textbook uses this as the ultimate cautionary tale of the screening radar gone wrong.
Prostate-specific antigen testing is the textbook definition of catastrophic overdiagnosis. The biology of prostate cancer is unique. It is incredibly common in elderly men. Autopsy studies show that a massive percentage of men in their 80s have prostate cancer cells. But the vast, overwhelming majority of those cancers are so incredibly slow-growing that, as the clinical saying goes, men die with prostate cancer, not of it.
But the PSA test finds it anyway.
It finds it brilliantly. Broad population screening with PSA tests led to an absolute epidemic of overdiagnosis. Millions of men were told they had cancer, resulting in a cascade of unnecessary, highly invasive biopsies, radical prostatectomy surgeries, and radiation treatments. And the side effects of those treatments are severe high rates of permanent impotence and incontinence. We subjected a generation of men to life-altering surgical complications without actually extending their lifespans, because the cancer wasn't going to kill them. Based on current, rigorous epidemiological evidence, the textbook is very clear. There is currently no case for broad population screening of, well, asymptomatic individuals for prostate cancer using PSA.
All right, let's pull all of this together and synthesize this deep dive. We've seen today that public health does not operate solely on polite persuasion or medical advice. It wields the immense, coercive, structural power of the law, and it deploys the vast, highly complex machinery of population screening. Both of these tools have the potential to save millions of lives, but they both require extreme vigilant restraint. They require a steadfast commitment to the true north of social justice, ensuring that our laws lift up the disadvantaged rather than entrenching inequality, and an unwavering reliance on cold, hard, epidemiological evidence to prevent state overreach and the hidden, devastating harms of overdiagnosis.
If we connect all of this to the bigger picture, the lesson for practitioners, lawmakers, and students is profound. We must always look past the superficial emotional appeal of simply doing something to fight disease. We must rigorously and honestly evaluate the hidden costs, the biases, and the unintended harms of our interventions before we unleash them on healthy populations.
I want to leave you with a final provocative thought to mull over as you head back to your clinics, your textbooks, or your morning commute. Consider everything we've discussed about the dangers of false positives and the popularity paradox. If our current legal and screening frameworks are already buckling under the weight of single disease interventions like breast or prostate cancer, what happens in the next 10 years when whole genome sequencing becomes cheaper than a standard blood test? When every single healthy citizen is suddenly transformed into a pre-patient carrying a digital ledger of 100 statistical genetic risks on their smartphone, how will public health law prevent the ultimate epidemic of overdiagnosis? And perhaps more importantly, will our constitutional right to privacy survive our deep biological desire to know our own future?
That is the exact question that will define the next era of our field. Now, to help you consolidate the conceptual frameworks we've discussed today and integrate them with your active reading, I have 5 rapid, single best answer style recall prompts. I'll read the question, pause briefly, reveal the answer, and tell you exactly where to look in the Oxford chapter to deepen your understanding. Question 1. Which legal tool is utilized when a government heavily restricts the marketing of sugary cereals to children on television? Answer. Altering the informational environment. You can review the mechanics of this in Chapter 3.4. Question 2. In population screening, if the baseline prevalence of a disease in a target population decreases due to better public health laws, which test property is most directly and significantly impacted? Answer. The positive predictive value, or PPV, will decrease. Review Chapter 11.4 for the mathematical breakdown of why false positives overwhelm the data. Question 3. A screening program detects a disproportionate number of slow-growing benign tumors compared to aggressive ones, creating a false statistical impression of improved survival. What is this bias called? Answer. Length time bias. This is detailed comprehensively in Chapter 11.4. Question 4. A municipal government passes a zoning law requiring all new urban developments to include separated pedestrian walkways and bike lanes. Which legal public health intervention model is this an example of?
Answer.
Altering the built environment or upstream engineering. This is found in Chapter 3.4. Question 5. What historical phenomenon, coined by Raffel and Gray, explains why a screening program that causes widespread harm through overdiagnosis often retains fierce, unyielding public and political support?
Did you?
Answer. The popularity paradox. Review Chapter 11.4 to understand the psychology of false positive survivors.
That's all for today's deep dive. We hope this conceptual companion helps structure your active reading and strengthens your system's reasoning. Keep questioning the invisible architecture around you, and we'll see you next time. Here are the details of this episode.
Law and the public's health. Byline. Power with restraint, using law to protect populations without overreach.